All right, let's jump right in. Today, we're basically going to be clinical detectives, solving a really common but super urgent medical mystery. We're going to walk through how to diagnose acute cholecystitis step by step, using a real-world case.
So, here's our patient. She's 45 years old, and she is in a lot of pain. She tells us it's right here, in the upper right part of her belly. And not only that, the pain is shooting up to her shoulder, and she's running a fever. Right away, these are major clues pointing us to a very specific spot.
Okay, so we've got the story, but stories aren't enough. We need some physical evidence. And this is where a good, solid physical exam comes into play. What's the one classic sign we can look for that might just crack this case wide open? And here it is, Murphy sign. This is such a simple but incredibly powerful move. You just gently press down in that right upper quadrant and ask the patient to take a deep breath. If they gasp and suddenly stop breathing in because it hurts so much, that's a positive Murphy sign. It's like their body is hitting the brakes, and it's a giant flashing neon sign pointing directly at an angry, inflamed gallbladder.
Now, a positive Murphy sign is an amazing clue. It really is. But we can't get tunnel vision here. A good detective never settles on the first suspect. In medicine, lots of things can look like something else. So we've got to build what we call a differential diagnosis to make sure we're not getting fooled by an imposter.
So let's look at our two main suspects, side by side. On the left, you've got biliary colic. Think of this as temporary. The pain comes and goes, usually after a fatty meal, and it resolves on its own, no fever. But look at the column on the right, for acute cholecystitis. The pain is persistent. It's been there for more than 6 hours. It doesn't go away. And there's a fever. Our patient's story, plus that positive Murphy sign we found, well, the evidence is really stacking up on one side, isn't it?
Okay, so all the pieces are fitting together perfectly. The patient's story, the physical exam, it's all screaming acute cholecystitis. But a really strong suspicion isn't a final answer. We need to see it to believe it. We need that definitive visual proof.
So how do we actually peek inside and see what's going on in there without, actually doing surgery? What's the best tool in our kit for getting a safe, quick look inside the abdomen? The answer is an ultrasound. It's fast, it's safe, and it tells us so much. And this right here is our diagnostic checklist. We're looking for signs of inflammation, like the gallbladder wall getting thick. Anything over 3 millimeters is a red flag. We might see some fluid hanging around the outside of the gallbladder. We can even do a sonographic Murphy sign, using the ultrasound probe to find the exact spot of pain. And of course, we look for the little troublemakers themselves, gallstones. Seeing this stuff on the screen, that's our confirmation. So, there we have it. Diagnosis confirmed. Case cracked. The investigation is over. But now, the action begins. The question changes from, what is it, to, what are we going to do about it? First things first, we have to stabilize our patient. That means getting that pain under control, getting some IV fluids in them because they're likely dehydrated, and starting some strong antibiotics to fight off that infection. Once they're stable, we move to step 2, planning for the permanent fix, which is surgery to remove the gallbladder. That's called a cholecystectomy.
Right, so we know surgery is the answer. It's the definitive solution. But the million-dollar question, the one we really have to get right, is when? When do we actually go in?
And here are our two main strategies. For most patients who are generally healthy, the evidence is pretty clear. You go early. Doing the surgery within 72 hours means they spend less time in the hospital and have fewer complications overall. But if the patient is really sick, has a lot of other medical problems, or the inflammation is just way too bad to operate safely, then we hit pause. We delay. We use antibiotics to cool things down and then schedule the surgery for a later, safer time. So, what's the big takeaway here? It's really this. For the right patient, getting in there early is almost always better. It's become the standard of care for a reason. It leads to better outcomes. In this case, waiting around isn't usually the best medicine. So, we have our diagnosis, we have our plan. But, medicine is never static. Things can change in a heartbeat. And that brings us to our final and maybe most important question. Whether you're planning surgery in a few hours or a few weeks, what are you watching for? What are the warning signs of complications that could pop up while you wait? Because being ready for that is the final piece of this whole puzzle.